يسعدني التواجد في هذا المؤتمر المتميز. I would like to thank Professor Amal Fathy for inviting me to share in this prestigious conference. I would like to thank the organizing committee also for inviting me to share in this prestigious conference. Mr. Chairman, let me speak about spontaneous bacterial peritonitis recent concepts. الحقيقة كان دايما بيخطر في ذهني سؤال، هو ليه الاسايتس بتاع الليفر سيروزز in particular اللي بتديفلوب spontaneous bacterial peritonitis. ومن هذا المنطلق لأنه الاسايتس بتاع السيروز، لأن السيروزز has many influencing factors in the development of spontaneous bacterial peritonitis، والكلام ده هستعرضه في السلايدز اللي جايين دول. There is strong link between sepsis and the liver. In patients with liver disease, the risk of morbidity is 30 to 50% higher than the 5 to 7% sepsis morbidity rate in the general population of hospitalized patients. Spontaneous bacterial peritonitis is diagnosed when there is polymorphinuclear leukocytes more than 250 per cubic millimeter and with positive culture. Spontaneous bacterial peritonitis and infection in general in liver cirrhosis leads to decreased survival and increased mortality in the liver ICU and the general ICU. Spontaneous bacterial peritonitis stands for the most common cause of infections in patients with cirrhosis, either in the general ward in the ICU. However, in the ICU, the pneumonia constitutes a larger sector of infection among cirrhotic patients. Spontaneous bacterial peritonitis and infection is a driving force for the development of acute on top of chronic liver failure with progression of the ACLIF from 1 to ACLIF 3. Cirrhotic patients has higher incidence of bacterial infections than the non-cirrhotic patient by 30%, with 60% of infections are community acquired and 40% of infections are nosocomial infections. So why we have to look for another alternate pathway other than the use of antibiotics in dealing with spontaneous bacterial peritonitis? This is because spontaneous bacterial peritonitis is not mere colonization of microbiome in the acidic fluid, it is rather a systemic disease. Changing pattern of the microbiome causing spontaneous bacterial peritonitis with emergence of gram-positive bacteria as a causative agent, together with emergence of wide-spectrum resistance to antibiotic. That is why we have to look for another pathway in management of spontaneous bacterial peritonitis. The liver, due to its location, liver is constantly exposed to antigens coming from the lumen of the gut through the portal vein and through the lymphatics. There are multiple factors participating in the causation or the pathogenesis of spontaneous bacterial peritonitis in cirrhotic patients, including clinical factors, genetic factors, microbiota factor, microbiota dysbiosis, and barrier failure and cirrhosis-associated immune dysfunction. If we look to this figure, we will see in the luminal contents the microbiota, dysbiosis of microbiota, and dysfunction of the mucin layer, of the mucus layer, of the mucous membrane of the gut, both share in the causation or the pathogenesis of spontaneous bacterial peritonitis by causing egress of the microbiome through the tight junctions of the mucous membrane, together with dysfunction of the immune cells, together with dysfunction of the immune cells in situ in the mucosa of the gut, and dysfunction of the immune cells in the circulation. All these factors share in the causation of or the pathogenesis of spontaneous bacterial peritonitis. Cirrhosis leads to liver insufficiency, portal hypertension, neuroendocrinal abnormalities, and together with etiological factors, all these sequences will lead at the end to development of spontaneous bacterial peritonitis. لكن الحقيقة أنا جايب الفيجر دي مش عشان أقولها كلها، لكن عشان أركز على neuroendocrine abnormalities with the sympathetic overdrive. The sympathetic overdrive resulting from cirrhosis leads to intestinal hypomotility or slow transit time. This slow transit time leads to bacterial overgrowth, which is a major determining factor in the development of spontaneous bacterial peritonitis. This will be explained in the coming slides. Slower intestinal transit time was found in cirrhotic rats with intestinal bacterial overgrowth, and slower transit time also was found in patients with spontaneous bacterial peritonitis. Intestinal transit time was prolonged in decompensated liver when compared to the decompensated liver. So patients with cirrhosis and ascites has more prolonged transit time than patients without ascites. Propranolol was found to fasten or enhance the motility of the small intestine. So propranolol was found to repair the defect of slow transit time. This resulted in decrease in intestinal bacterial overgrowth together with decrease of bacterial translocation to the mesenteric lymph node. Actually, there is much controversy about the use of non-selective beta blockers in patients with ascites and liver cirrhosis. But the study showed that non-selective beta blockers increase transplant-free survival and decrease the length of hospital stay in patients without spontaneous bacterial peritonitis. However, in patients with spontaneous bacterial peritonitis, non-selective beta blockers reduce transplant-free survival and increase the length of hospital stay. So with spontaneous bacterial peritonitis, it is hazardous to give non-selective beta blockers. However, before development of spontaneous bacterial peritonitis, maybe non-selective beta blockers would be of a beneficial effect. This depends also upon the dose of the used non-selective beta blocker. Propranolol in 80 milligram per day resulted in increased survival even more than the non-use of non-selective beta blockers. However, with 160 milligram, it resulted in decreased survival than the placebo. Cirrhosis causes structural and functional changes in the mucosa of the small intestine, leading to increased permeability and bacterial adherence to basement membrane. We will stress furthermore the bacterial adherence to the basement membrane with looking for this slide where the mucous membrane forms an outer layer and the inner layer the mucous membrane is considered to be another organ in the gut, in the mucosa of the gut, controlling the dysbiosis or the healthy integrity of the microbiota in the lumen of the gut. So this mucin or mucus forms a trap for the microbiota, making it difficult for the bacteria to get access to the mucous membrane of the gut. However, with this function of the mucus, the bacteria will be dispersed and can get easily access to the mucous membrane of the gut. So the hypothesis is that in liver cirrhosis, it reduces mucus thickness due to a reduced number of goblet cells and mucin gene expression independently of the microbiome. Another interesting finding is that lack of intestinal bile reduce the mucus thickness independently of the microbiome. So bile plays a major role in the integrity of the healthy character of the mucin layer covering the mucous membrane of the gut. Furthermore, 3-day high-fat diet is sufficient to induce marked alterations in the mucosa associated microbiome. This may explain why patients getting a high-fat diet, and even if they are lean, develop NASH or NAFLD. This picture is produced by confocal lens endomicroscopy، وفي دكتور من المنصورة أنا الحقيقة مش فاكر اسمه اتكلم في جلسة من جلسات امبارح عن الاندوميكروسكوبي. This is in vivo histological study of the mucous membrane of the gut by confocal lens. This figure shows the tight junctions of the mucous membrane of the mucosa of the intestine. The tight junctions get lost and the overlapping is lost and increased permeability with bile duct ligation. So bile duct ligation resulted in increased permeability and the loss of the overlapping of the tight junctions of the mucous membrane. A bacteria was found in the lamina propria and the perivascular space with bile duct ligation. So bile, another important item here is that bile plays a major role in the healthy integrity of the mucous membrane of the mucosa of the gut. So bile acids are bacteriostatic. Bile duct obstruction or ligation causes proliferation of intestinal bacteria and mucosal injury, leading to bacterial translocation. Oral administration of bile acids inhibits bacterial overgrowth and bacterial translocation caused by biliary obstruction in rodents. Furthermore, liver cirrhosis, but not portal hypertension, leads to increased extravasation of high molecular weight molecules through the mucous membrane of the gut, meaning increased permeability. Increased bacterial translocation to mesenteric lymph nodes in experimental cirrhosis with ascites. It is evident that here in this figure, the translocation is more in patients with ascites rather than cirrhosis without ascites. Here also, the bacterial DNA found in mesenteric lymph node was much higher in patients with cirrhosis and ascites rather than control. So bacterial translocation occurs exclusively in cirrhotic patients with ascites. Culture of mesenteric lymph node which indicates bacterial translocation is correlated with the stage of functional stage of the cirrhosis being more with child C than child B and child A. Increase the passage to the systemic circulation of bacterial products of enteric origin in patients with cirrhosis and ascites. This is detected by assessment of lipopolysaccharide binding protein in the serum and the bacterial DNA in the serum. It is evident from the figures that the bacterial products in the serum are much higher in cirrhosis with ascites in relation to control or cirrhosis without ascites. Liver insufficiency, but not portal hypertension, is a key factor for the development of gut bacterial translocation in cirrhosis. This is together with هنتنقل بقى للنقطة الثانية اللي هو immune cells in the mucous membrane or the mucosa itself. There is decreased phagocytic activity of dendritic cells of the mesenteric lymph nodes of cirrhotic rats. واضح من الفيجرز is the decreased activity of the dendritic cells. This is the dendritic cells engulfing bacteria together with damage of the effector intraepithelial lymphocytes in cirrhosis. If you look for the figure, you will find that the immune cells in the mucosa is much lower, significantly lower than the control. Gut bacterial translocations renders the mesenteric lymph node a cytokine releasing organ in cirrhosis. النقطة دي مهمة جدا لأنه مش بس عشان السبونتينيوس bacterial peritonitis، لأنه in patient with cirrhosis and ascites, mesenteric lymph node is becoming a hazardous organ. It can be considered as a hazardous organ, releasing inflammatory and the bacterial products to the circulation with the sequences which we'll discuss later on. So mesenteric lymph nodes with bacterial translocation is considered as cytokine releasing organ in cirrhosis. This figure shows the release of cytokines and the bacterial products from the mesenteric lymph node to the circulation. Activation of the second step is activation of the inflammatory immune system at the systemic level in patients with cirrhosis, ascites, and high lipoprotein. This figure shows that the elaborated bacterial products and cytokines, the pro-inflammatory cytokines, will have its impact causing dysfunction of multiple organs, including neurons, endothelium, adipocytes, and osteoclasts. In summary, clinical prevalence of pathological bacterial translocation in liver disease causing spontaneous bacterial infections in cirrhosis, contributing and aggravating complications of liver cirrhosis, such as hepatic encephalopathy, renal syndrome, liver failure, and involved in pathogenesis of many liver diseases, including NASH, cholestatic liver disease, primary sclerosing cholangitis, EHGC, and is the driving progression of liver fibrosis and cirrhosis in various etiologies. Bowel decontamination was found with antibiotics was found to reduce inflammation both in the mesenteric lymph node and in the blood. So prevention of bacterial infection is our aim in controlling the development of spontaneous bacterial peritonitis rather than treating the current state of spontaneous bacterial peritonitis. So it is a potential, there is a potential alternative to long-term antibiotic therapy in cirrhosis with the use of probiotics, prokinetics, beta blockers, انكسوبارين. انكسوبارين اللي هو لو مولكولار ويت هيبارين. الحقيقه دي البيبر دي بتاعت إريكا فيلا. إريكا فيلا جت في المؤتمر بتاعي سنه 2010 الحقيقه، وست ممتازه قوي الحقيقه، وهي ماسكه دلوقتي اديتور اوف ان تشيف بتاع البلوس، مجله بلوس الحقيقه. هي كانت عاملاها that 1 year low molecular weight heparin in cirrhotic patients to guard against development of thrombotic complication. لكن وجدت ان inflammatory mediators are decreased في البيشنتس اللي خدوا low molecular weight heparin. يعني الصدى حلوة قوي. So the use of probiotics, prokinetics, beta blockers, وقلنا بدوز lower dose, and enoxaparin, and the use of FXR farzinoid receptor agonists such as obticolic acid. It was found that diminished FXR signaling in the intestine could be a background of increased permeability. Obticolic acid reduces bacterial translocation to mesenteric lymph nodes in rats with experimental cirrhosis. Take-home message: restoration of the healthy integrity of the gut-liver axis is the mainstay target in prevention of development of spontaneous bacterial peritonitis and hence alleviation of the associated systemic diseases. Modulation of pathophysiology of bacterial translocation can be tried with non-selective beta blockers in lower doses and in absence of spontaneous bacterial peritonitis. The possible use of bile acids and FXR farzinoid receptor agonists such as obticolic acid is another pathway. In critically ill patients with refractory ascites, modulation of the gut epithelial and systemic immune cells through immune checkpoints inhibitors can be tried. Modification of the microbiota dysbiosis by prebiotics, probiotics, and the fecal matter transplantation should be studied and considered. And thank you very much.